Good afternoon, good evening. Thank you so much for joining us for the weekly press briefing from Africa CDC. My name is Margaret, Edwin, the Director of Communications. I will be moderating this session. The weekly briefing touches on health emergencies across the continent, and today we are joined by Professor Yap Boom, the Deputy Incident Manager at the IMST based in DRC. And I will now hand over the floor to Professor Yap to start the session. Over to you, Prof.
Good afternoon, Margaret. Good morning, good afternoon, and good evening to all who are joining us for this press briefing that I will be doing on behalf of our DG, who is not able to attend, and our apologies for the Minister of Health of Sierra Leone, who unfortunately will not be able to join as promised last week. So I will first thank the journalists who for the continued support of our activity, to follow up. We mentioned that it's also a way to account for us, to our leaders, to our donors, to our sponsor. And when we see some of those articles, editorial and all that we've seen last week, we really feel that we are supported, we are challenged, and then we'll keep on doing the best to ensure that we provide the best response to our communities. And also to the team that are tirelessly working in all those countries, Sierra Leone, DRC, Uganda, Ethiopia, and everywhere, ensuring that they have our full support, and then we keep ensuring that we will be close to the member state, and hopefully we will be able to see the end of this outbreak. Over to you, Director. Next slide. So this week has been happening the African Health Excon 2025, which is happening in Cairo. And this is a great platform where leaders in health are really thinking on how we can improve the health in our continent. One of the focus this time is how to advance the health innovation and sovereignty. And the focus area is how we can strengthen the Africa health regulatory system for quality medicine and healthcare product, advancing health sovereignty through local production and reduce import dependence. That has been one of the key pillar and advocate of Africa CDC on the local manufacturing agenda. And the third one, but not the least, is really to fostering partnership to improve regulation, digital health, and capacity building. So really it's the time where we pause as a continent to see how we can embrace the model tool. We've talked about the AI and many others to ensure that we are the more inclusive and to build future-ready health system. Next. Another big event for this week is the getting out this article that was out in Vaccine on the strengthening national regulatory authority in our continent. So this is really a critical step where we really want to enhance the local manufacturing of vaccine and health products. So as in one side, we are pushing the agenda, the tech transfer. In the other side, it's critical to have the adequate regulation. So we have 8 countries that have reached WHO maturity level 3, and which is completely a significant milestone in strengthening medicine and vaccine regulatory system. So here we are looking at 2 things. First, how we can keep on improving the regulation, enable safer, faster approval of locally produced medicine and vaccine, boosting the self-reliance, so that once we have one product that is approved in one country, how to fasten the process so that the other countries could also endorse that medicine or that vaccine. Now, in terms of regulation, also is to strengthen the national regulatory authorities to ensure high-quality health products, safeguarding millions across the continent. So they should really be equipped so that they can have what is needed to do a proper assessment to whichever drug, whichever vaccine, whichever diagnostic that is being made locally, and that therefore be used in a safer way in our continent. Next slide. Drug, whichever vaccine, whichever diagnostic that is being made locally, and that therefore be used in a safer way in our continent. Next slide. Of event, the high risk, the moderate, you can see that while we are in June, mid of this year, most of those events are more than what we had last year at the same time. They are more than half of what we have in 2024, which is showing the increase on those public health events in the continent, therefore pushing us, challenging us on being more efficient on how we respond, how we need to integrate the response to those different public health events. Next slide. Going back to Mpox, as I mentioned, this is the second event in terms of number of suspected cases that we've been seeing in the continent after cholera. But this week, we keep on seeing a trend in the decline in the number of suspected cases notified, but also in the number of confirmed cases. This is very encouraging because this also helps us to see the light at the end of the tunnel as we move forward. You can see that in June, we've already reached the 94% of the suspected case as compared to 2024, and with beyond the 100%, 109% of what we have last year in terms of confirmed case. So we see the decline, and as per this week 24, Sierra Leone was accounting 41% of the confirmed case, which is also in decline as compared to the 53% that they were representing last week. Next slide. In terms of clade, it's important, as mentioned last week again, that we are dealing to multiple outbreaks. And when you see the evolution of the different clade, we've been dealing since last year to our outbreak, mainly led by the clade 1B, which is coming from DRC, that has been the epicenter. But now in West Africa, we have the clade 2B that has been spreading in Sierra Leone and other countries. But even when you see both of them, we appreciate the decline that is happening regardless of the different clade. Though we need to be very cautious, as I will say, we are quite encouraged when we see the trend that is being shown in this slide. Next slide. The top countries that report 87% of the confirmed case, naming the DRC, the Sierra Leone, and the Uganda, are also showing that decline, though they still represent 87% of the confirmed case and 91% in the week to 23. So we appreciate that decrease, which also showing that other countries will start with, that I will show later on, also account for a bit more than the case that we were seeing last week. So the consistent downward trend is ongoing. This is quite encouraging, but also highlighting the measure that countries are implementing in a very different way, as we will be seeing, which emphasize the need to contextualize the response. The way the response is happening currently in DRC, in Sierra Leone, and in Uganda are quite different. We've mentioned the DRC is affected by the clade 1A and 1B. Sierra Leone is 2B, while Uganda is the clade 1B. So they have different clade, they have different social behavior, and then they are all pushing with the support of the continental IMST to ensure that the response is really contextualized and the solution adapted to their community. Next slide. In DRC, where we are currently, we are also seeing that decline in the notified case and stabilizing in the confirmed case. The testing rate is quite great at 100%, but the testing coverage still a challenge. So we are seeing 39%, 29.8 in terms of test positivity rate, which is on that side quite good. Why the challenge of testing coverage? What that means? It means that though we are not able at this point to have all the suspected cases being tested, at least the test positivity rate being around 39% show us that the surveillance is happening in the community. The intensification is producing its fruit, but we need to accelerate that intensification so that we carry on the same test positivity, ensuring that the surveillance is happening at the community, but we should transform every single alert into testing and ensure that we have a better understanding, reaching the 80% of testing coverage. And when we look at the provinces that are currently showing North Kivu, Kinshasa, Sud Kivu, Tanganyika, Trapa, and Equator are accounting to the large majority of the confirmed cases that we are seeing. Next slide. Now, in Sierra Leone, where we had the high-level visit last week, we are also showing that encouraging decline. You will see in the notified case, we are 282 as compared to 357 last week, but also in terms of the confirmed case. So this is very, very encouraging. Moreover, testing coverage is very high, 100%, as well as the testing rate. And the challenge remains on that test positivity. That's why Africa CDC is supporting the country in rolling out the community healthcare worker, so that we have those 200 community healthcare workers who will be in the field, moving house by household to ensure that the track define all the active cases, and that will make the link with the vaccination and ensure that those who are at risk are actually the one moving house by household to ensure that the track define all the active cases, and that will make the link with the vaccination and ensure that actually the one in one side taken care of in the health facilities, and also those who need to be vaccinated actually receive the vaccine. Next slide. Now, Uganda, which is, as mentioned, is affected by the clade 1B, the situation is stabilizing. We have currently 71 out of 145 districts that remain active. We see that decrease that you will see in the graph in previously high burden district. Kampala is still has been seeing no case for the last few weeks, which is again quite encouraging, knowing that this was really the epicenter and the highest hotspot. An aggressive vaccination campaign has been happening in the different districts and provinces of Uganda, and we are happy to see that decline trend. The test positivity rate is around 48%, so some effort has to be done, but still we can see that the surveillance in the community is working. Now, when we look at the death, we can still see that half of them are people living with HIV. That's one of the key reasons why the country has really emphasized the vaccination of people living with HIV so that they can be protected. Yes, they can be exposed and to the virus, but then they won't be able to have those severe form, and then being the most people will be most likely dying. Next slide. Burundi, it's definitely the country where we keep on following in a daily basis, in a weekly basis, to ensure that we reach the last mile. As you can see, only 6 districts are still reporting some cases, while in the peak we were having 29 districts that was reporting some cases. The testing coverage, the testing rates are all great. The test positivity is around 45%, which means the surveillance is good in the community, but can be improved. And that's why they've extended the community health care workers who can carry on to ensure that we keep on reducing those districts that are reporting cases. And moving from that to the legacy, where they will actually use the model for Mpox they've done for the lab by publishing the decentralization laboratory guideline, which will now be transformed at the continental level. So it will be critical also to learn how the experience of Burundi, and to see what can apply to other countries. We appreciate that we cannot just duplicate, but it's good to have those best practice. That's why we will soon organize a workshop where the Burundi will come with other countries to share experience and to see what can be learned from one country to the other, so that we all reach the final line of controlling this outbreak of Mpox across our continent. Next slide. The situation in Togo, we can see an increase in the number of suspected cases notified, but also the confirmed case. We currently have a team for IMST that has visited the country to actually sit down and see what are the lessons learned in other countries that can be implemented at this stage, so that we control the outbreak, avoiding the increased number of cases that we've seen in many other countries, so that we can appreciate the good effort that the country is doing, as we can see with the testing coverage of 100%, testing rate of 100%, test positivity rate quite good as well, showing the surveillance is ongoing, but also responding to the requirement, the needs from the country in terms of diagnostic, in terms of sequencing, so that they have all what they need to control. We all appreciate that prevention is better than cure. That's why we really want to support some of those countries with few cases to ensure that we control at this first level and avoid the outbreak to spread within those countries. Next slide. In Kenya as well, we've seen an upsurge in case since the week 14. Twice the observed average in previous year, so that is important to notify. But when we come to the testing coverage, quite high testing rate as well. But the testing positivity, we can see that from last week to this week has increased 68%, which means here again, we need to make the emphasis in the surveillance in the community through the community health. And see that from last week to this week has increased 68%, which means here again, we need to make the emphasis in the surveillance in the community through the community healthcare workers without peace. So we really hope that the demonstration will stop and that the community will be in a better position to control this outbreak, but also to go back to peace and have a better environment. Next slide. In Ethiopia, we see an increased number of notified cases, almost doubling, showing that the surveillance is in place, the alerts are being collected, the testing coverage is 100%, which means also that all those alerts, the patient has been sampled, the sample was sent to the lab, and the results were used. Now, what is important also to see is the decrease in the number of confirmed cases from 12 to 1 in that week. The deaths are still at 0. Having that distribution and that low number of cases, it's again the time to support the member state, Ethiopia, and ensuring that we control when we are still at that stage. That's why we'll have that conversation with the country to have a high-level visit that will go and meet the authority to see how Ethiopia, and ensuring that we control when we are still at that stage. That's why we'll have a high-level see how the IMS provide adequate support at this stage to actually strengthen what is already present, the coordinated response, but also enhance the border monitoring, the integrated community surveillance, which we've already mentioned, which is key, not only for controlling the outbreak, but also for making the link with the vaccination targeted that is needed to control the outbreak, as they've been doing already with the polio and other disease. The isolation centers are in place in affected and affected regions. That's something that we should strengthen, support, and ensure that the proper secret is in place, the proper triage is in place, and catalyze all the already existing effort that the country is putting in place. Next slide. Now, when we look at the vaccine delivery and the implementation status, we have 11 countries that have received the vaccine, 7 countries that are currently vaccinating. Almost 700,000 people have already received the vaccine. 15 countries grant the approval for MVA-VN. Malawi has just granted it. But the challenge on those approval, one of the biggest challenges is that most of the country, apart from DRC, has an approval for children below 12. While we know that in many countries, the children are also affected. So it's a continuous call that we are making for the member state to ensure that they also grant those approval based on the evidence coming from DRC that the vaccine is safe, is actually protecting that population. Now, we have 6 countries currently within the demand pipeline. So those are countries that have seen some case. They've written their plan on how they would like to use the vaccine, and they've made the request. But as we do speak now, we are challenged by the shortage of vaccine within our pool. So that is also an advocacy to the work that we are doing to mobilize more doses of vaccine, especially from those new countries. We appreciate that vaccination is not a silver bullet, but it is a key component of the response because countries are different. The experience of Burundi might be difficult to implement in all the different countries. So in some countries, it's possible to do without, but others will definitely need. And at this very point of time, we don't have those extra doses for the new country. The new shipment of Uganda has just received 97,000 doses, which is part of the 3rd round of allocation. Next slide. So this allocation will allow the country to move to the 4th round. As we do speak right now, the 3rd round has helped the country to use 93% of the 100,011 doses that they've been received. That's why we also hope in the following weeks to be able to assess the impact of the vaccination in that country. In Sierra Leone, the 2nd round of vaccination rollout has started. So the aim is to vaccinate 66,000 of people within 10 days. And that is a targeted approach where the hotspot has been identified in 16 districts, and they will target the population and the key population. They've looked at the epidemiology, look at those who are the most at risk, the students, the sex workers, and so on, people living with HIV, so that those ones are prioritized because of their condition and also because of the role that they can play in the spread of Mpox. Now, in terms of continental, we've managed to raise 3 million doses so far, but as mentioned, we needed 6.4 million. So we are still far from the target. And with those new countries coming in, we are very challenged not to have the available dose to support them. We recently have the bilateral donation of 65,000 doses to DRC, which has allowed to Sierra Leone by DRC, which has allowed the country to start the 3rd allocation, the 3rd vaccination campaign that I was mentioning. And DRC accounts for 77,000% of persons vaccinated. Now, with the 1.5 million doses of LC16 that they've received, they've launched last week the vaccination, and they are finalizing the plan on how they will be using those extra doses that they've been receiving from Japan. Next slide. Now, cholera. Cholera, as you will see in this slide, at June 23rd, we are already more than half of the total case and death that we had in 2024. Africa represents 60% of all cases, but also 93.5% of all the deaths are happening in our continent. We currently have 21 member states that are affected, which highlighting how critical it is for the continent to have that regional and coordinated approach to see how we can really tackle this cholera at the regional level while strengthening the country in the leadership to actually respond and having that multi-sectorial approach, because as much as we want, it's important to highlight that the cholera need a multi-sectorial approach. It's an issue of access to water, and that is not the mandate of the Ministry of Health. That's why the head of state has made that call of action to have the multi-sectoral approach and also to use the MST experience that we've seen during Mpox to see how we can have that approach for cholera. Next slide. Now, going to DRC, where we are currently, we see an increase in the number of cases, 1,218 as compared to 1,237 that as we see last week. We still see an important proportion of children are affected. 40% of the cases are actually children. The vaccine coverage, the OCV, is only 7%. And the hotspot that has been identified are Haut Katanga, Nord Kivu, Sud Kivu, Olomami, and Tanganyika. And as you will relate, Nord Kivu, Sud Kivu are also the same provinces where we do have Mpox, where we have measles. So you can imagine the challenges for the team, for the country to actually respond to those outbreaks at the same time, and therefore the need to have a stronger integration. But some of the drivers include the flooding, the increased water contamination, especially in the South Kivu, that has been affected by the crisis, but also in others like Tanganyika, the cross-border spread, and the collapse of the urban water system. So when you look at it, you really appreciate that it's far beyond being an health issue, and the advocacy to embark other ministry like the Ministry of Water and Sanitation, the Ministry of Finance, so that the fund might be available, is really critical. And this is why the head of state have recommended, as I already mentioned, to have that regional coordinated approach to address the challenge of cholera in the continent. Next slide. In Kinshasa, as we are right now, we can see a decrease in the number of cases. As you can see, almost half of the case, but still having children representing the highest number. And this is due to the recent flooding that has been reported a few weeks ago, which continue to increase the risk of spread affecting the vulnerable population. I mentioned 40% of them are children, but this is happening mainly in slum and planned settlement, highlighting also the connection between cholera and poverty. So it's really requires a strong political approach to respond to this outbreak in Kinshasa, in DRC, and in other countries, as I will just see later. Next slide. In Angola as well, we keep on following the decrease in the number of cases, though they still remain pretty high, 810. The case fatality ratio is also decreasing with 12 deaths in the week as compared to 13 the other week. 50% of the cases are male, and you will see that, as we've seen in DRC, the children are around 38% as compared to 40%, which is almost the same in DRC, and they represent here 32% of all deaths. This is the key vulnerable population. The vaccination that has started at some point need to be strengthened. 57% of the deaths are happening in the hospital, which also emphasize the need to keep on pushing, increasing the surveillance at the community level to ensure that we don't have 33% or 43% of deaths happening in the community. That is quite critical. So the seventh phase of the OCV vaccine administered has been happening in Rwanda, in many other places, with the great support of UNICEF. Next slide. In Sudan as well, we see the decrease in the number of cases, as you can see, but the number of deaths are significantly increased, which is quite challenging and alarming. So we had a conversation with the country to have a better understanding of the drivers of the deaths, so that we can bring the appropriate support. And this is despite the challenging humanitarian crisis that is happening in the country. So the targeted attack on water and power infrastructure and limited access to clean water and healthcare services continue to exacerbate the risk of spreads. Again, there is no health without peace. So it is critical to have the peace so that the humanitarian actor can actually work on providing access to water and take care of those patients so that we can avoid having such a high case fatality ratio. Next slide. So in summary, this week, we have some very encouraging result. We can see that the Mpox case are declining. So in summary, this week, we have use of every single dose of vaccine that we do have, while we are pushing the global community to mobilize more vaccine. As we do speak, as I mentioned already, as per now, we have many countries, 6 countries actually, that are in the pipeline requesting for vaccine, but we do not have, at this point of time, vaccine that are available with operational costs to actually support those countries. So that's a big, big challenge. In terms of cholera, we see the decrease, and which is also encouraging, but it remains a concern. Where we see the continued spread in several countries. We've mentioned the top one, the Sudan, South Sudan, DRC, and Angola, and this is worsened by the climate change and, of course, the humanitarian conflict in those countries. So with all that, Mpox, cholera, we really need to push and implement the call of action of the head of state to have that integrated response strategy. So with that, thanks you, and I'll be happy with my colleagues to respond to your question. Over to you, Director Margaret.
Thank you, Prof. Let's cross over to, we have Paul from the Lancet. You have the floor.
Yes, thank you very much. So my first question has to do with around health security. A couple of weeks ago, May 29th to be exact, the WHO announced the extension of a program that also involves Africa CDC, which is the HSPA, that brings together health and security. And I think it was first started out in 6 African countries. Now is expanding to Rwanda. If it's possible, I'd like to know what the insights from the test initiative is. I'm thinking that the second phase has a deadline of 2028. I'd like to know if one of the bigger plans is to integrate the outtakes from this initiative into national health systems. And I also want to have a question around genomic surveillance. Recently, I read a paper from Nigeria that showed that sustained human-to-human transmission of Mpox has been going on since 2014. Do we think the nature of transmission of Mpox is going to impact how we respond to it, probably as a human infection, as an endemic human health threat, rather than a zoonotic spillover? And if I can just squeeze in one more, I don't know, are we expecting to have CPHIA this year, or a decision has not been made yet? Thank you.
Thank you, Paul. I'll hand over to Prof for his response. Prof, over to you.
Yes, thank you, Paul, for your great question and for sneezing all of them within one time. So I will start with the latest one, the CPHA. We are really working on that. So as soon as we have the outcome, we will communicate broadly on the date and the place where it will happen. So now on the transmission, is true that we are moving from a zoonotic disease where we were really seeing the spillover that are still happening in some countries. In CAR, for example, we are really mainly relying on the spillover, while in other countries, Sierra Leone, Uganda, and other is only human-to-human transmission. Is it going to change how the way we respond? Definitely. That's why it is critical for us to document, to use the genomic sequencing to ensure that we are in the best position to track the virus. Just one example. You mentioned Nigeria. So in Nigeria, we were moving from animal to human, but with those different mutations, and the spread currently is mainly human to human, which is happening in Nigeria, but it's also moving in Sierra Leone. which means depending on the clade, depending on the country, we must have a different approach. When we will, for example, target in a country like Central African Republic, in terms of people that you would like to target in terms of vaccination, you will definitely include those people who are in contact with the animal. You have the people who go to the hunters, the sailors, and so on. But when you will go to other country like Uganda, you will definitely don't look at the same population. So we are learning as we go through this outbreak, and then we'll come with those revised guidelines on how we respond to this outbreak. 2 weeks ago, we did the same exercise for the case management, where we have different partners led by the WHO to look how we can use the lesson learned in terms of case management of Mpox in different countries, looking at a different plate because we have different manifestation. So we'll do the same thing for the different pillar, and then we'll have a response that will be easy for member states to contextualize, not based only on the country, but based on how the outbreak is starting. Is it from the animal side, or is it strictly from the human transmission? Now, in the issue of health security extension, it is definitely one of the key points that is being discussed at the ESCON. So I believe that next week, once it's done, we'll have more information and we will be able to provide to you more insight on how we are moving on that point. Thank you.
All right, let's cross over back to the floor. We have Kemo Cham from Mano Reporters. Kemo, you have the floor. Over to you.
Hello there, thank you. Doctor, you spoke about the need for member countries to consider vaccinating children. I would like to know, when you engage these countries, what are the main reasons that they are for not doing that now? And while at it, if you can mention what response you got from Sierra Leone in particular. Thank you.
Thank you. Let's get the other question before Prof comes in. We have Gabriel Emmanuel from NPR. Gabriel, you have the floor.
Hi, thank you so much. I actually had a question about
from Sierra Leone in particular. Thank you.
Thank you. Let's get the other question before.
Yes. It's called FuseNet. It is the famine warning system that was funded by the U.S., although implemented by a partner who they contracted with. FuseNet. It's an acronym that stands for, I think, hold on, I can tell you exactly what it stands for. It stands for the Famine Early Warning Systems Network. And it went down months ago with the Trump administration. It was relaunched on Tuesday.
Okay, I will let Dr. Messi to respond to that question on the surveillance, and I will give a feedback to Kemo on the vaccination in children. The process is country make a recommendation based on the feedback from the NITAG, which are the committee which advised the Ministry of Health on the issue of vaccination. So the first question that was asked for to most of those NITAG, based on the evidence that was available, was whether they can use the vaccine, and the vaccine approved in those 12 to 8, beyond 12 years old. So that has been the case. So now most of the countries are still in the process of going back to those NITAG, and currently, as we do speak, there is the RITAG, the regional body that is sitting in Brazzaville, the other side of where we are currently, discussing how they can have a regional approach to respond to such questions, such like the one we are asking in children. So different countries are in different stage. On some of them have already asked the question to the NITAG, so they are looking the feedback from those one, and others are still in the process of making the recommendation. But in any discussion that we have, in any engagement, when we go to country, we look at the epidemiology. This is the driver. We see, okay, when you look at what is happening in the country, you can see that you have a significant proportion of children that are also affected. Even if the key population affected are the adults through the sexual transmission route, when they go back home, it will move within the household. So definitely you need to protect those children. The second point that we always highlight is what is happening in DRC. They follow up the adverse event, the MAPI, and we have not seen big MAPI in those that population, which is quite encouraging. And as mentioned, more than 27% of the population vaccination in DRC are children. So it's quite encouraging in terms of efficacy, in terms of safety, more importantly, so that we can reassure the country. And then we hope that the right tag, when this week ends, they will go back to their country and accelerate the process of giving feedback to the Ministry of Health. So for the FuseNet, I will hand over to Dr. Mercy. Thank you.
Thank you so much, Prof, for that question. And I think that's a very important one, especially if you're looking at the impact of the global freeze on some of the early warning systems, especially looking at it from the FuseNet, that's really supporting the different countries, especially those that are hit with food shortage or say food insecurity. I mean, that's really pertinent. But as you know, the mandate of Africa CDC is mainly around ensuring that we have resilient health systems that are able to prevent and also prepare as well as respond to public health threats. However, we have other AU agencies who are mandated to look at those critical issues like the AU NEPAD, as well as we also be checking with our colleagues from the AU AIBA, who are also supporting the animal health and of course food production within the animal space, to also understand how they have been tracking these issues, and we'll be able to consolidate those findings and come back to you. So we have other agencies that are really mandated to follow up on poverty eradication as well as food insecurity. Over.
Thank you, Dr. Mercy. Let's take the next two questions. We have Stephen from Premier News in Sierra Leone. The question is, the demand for Mpox vaccines is high in Sierra Leone, but its availability is limited. How can such be addressed in Sierra Leone and other West African countries? That's the first question. And the second one is from Joy of Duma FM in Botswana. The question is, Botswana in Southern Africa is in the middle of the winter season and temperatures have rather been harshly low. A majority of the people have experienced a strange wave of flu, which is suspect as a new strain of COVID. What is your take, and are there any updates on cases of COVID? Over to you, Prof.
Thank you very much. I will leave the question on COVID to Dr. Cheng. So for the issue of vaccine availability, vaccine demand is very much. I will leave the question on COVID to Dr. Cheng. So for the issue of vaccine availability, vaccine demand is specifically in first to appreciate that there is a high countries, especially in Sierra Leone. Now, Sierra Leone has received 95,000 doses of vaccine in the recent weeks, 75,000 bilateral donation between DRC and Sierra Leone. And prior to that, they've received 20,000 from the United Emirates Arabs. So currently they have more than 100,000 doses, and they've launched that third round, which is targeting 66,000 population in the hotspot. So we believe that this investment in the next 10 days, they will absorb those doses and we'll be able to follow up and see how the situation is improving. Tomorrow, we'll have a call with the team on Sierra Leone to see how it's being implemented and how the recent donation affect their demand. Do they need more, and in when? Because as mentioned again, there is no much vaccine available at the regional, at the global level. So each dose must be used in a very efficient way. So if this campaign is well implemented, as our colleague was quite impressed when the Minister of Health of Sierra Leone did present the strategy. We were quite impressed to see that the country has really take all the recommendation, looking at the epidemiology and really specify where they want to implement the vaccination. So just to highlight that it's not a silver bullet, one. Two, it has to be used in a very efficient way. In Sierra Leone, in Uganda, in many of those countries, because we have those 6 countries that are in the pipe asking for a vaccine. But before we reach to the vaccine, we need to use all the other response that we have in our mind. The community-based surveillance, the IPC, which will be able to help us to control the outbreak as we did all together in Burundi.
Thank you, Prof. There was another question on COVID-19.
To Dr. Mercy.
Yes, thank you so much. So I think this question came out last 2 weeks when we had the last briefing around the new variant for COVID. And we initially had mentioned that, this is a variant, of course, stemming up from Omicron. And from the available information that we do have at the moment, there is really nothing to be alarmed or to be so worried about. For if it's actually the NBI 181, which is the Nimbus variant that's currently being reported. It's a variant under monitoring as per the WHO definition. And while there are a number of cases that have been reported across the continent, in other countries, say in the US, that we have substantial data on, as well as other European countries that have reported the same, we're not seeing high case fatality rates. We are also not seeing high hospitalization rates, which are the 2 markers that really point to severity of the variant. So for that, if that's the variant we're looking at, then nothing to really be alert of. But we keep a close eye on it, and we continue to monitor. On the continent, we've also received similar reports, especially for countries that have established the influenza-like illness, as well as the severe acute respiratory infection surveillance system, which is the SARI system that countries are actually using to monitor influenza and acute respiratory diseases. Some countries have been able to integrate COVID into that space. So amongst the diseases under that group of influenza-like diseases, so they are currently monitoring, and this is currently being done within the sentinel sites that have been established. An example is South Africa, that has a very robust sentinel surveillance for SARI, and they're really doing a very close monitoring on the same. So if there's anything that would call for alarm that Africa CDC needs to come out to the press, to tell the press, to talk to the press about, definitely we'll be bringing it out. But as of now, the current information that we have based on data that is available does not really point to a situation that should be worrisome. Oh.
Thank you, Mercy. This also highlight that we do have those outbreaks, those public health events, and we'll have much more than them. What is important is not that we'll reach the 0 case in every country. The most important for us is to ensure that the countries are able, one, to do that surveillance and to know where the number of cases are beyond what is usual, and therefore to be in a position to implement the response in terms of monitoring, in terms of surveillance, in terms of IPC, and so on. So this is also what happened today in DRC, where they were having a meeting on asking, where do we want to go in terms of Mpox? When are we going to tell that these provinces or the countries is out of Mpox? Which does not mean 0 case, but when region will go back to the level of endemicity. So this is important to highlight, because we might not reach to 0 Mpox case at the end of this outbreak, but we will have to decide what is the level that we support reasonable, because countries are equipped to adequately respond and control the disease.
Thank you, Prof. Let's take the next two questions. We have Michael Guarisa, is a Health Times journalist from Zimbabwe. What is the status of the oral cholera vaccine supply in the region, and how many doses are people in affected communities getting? And also, how many vaccines do we need to address the cholera burden? Those are the first questions, and then we have one other question here on Africa CDC's piloting the health financing concept. So the question is, what has been the results of Africa CDC piloting the new health financing mandate? Over to you, Prof.
Thank you. So on the actual stock for the OCV vaccine, we will see if Dr. Messi has them. If not, we'll communicate later on. For the health financing concept, we are happy to see that, first of all, our Green Book has been adopted by a number of partners, a number of institutions, which is already a great sign. We are also happy that at the highest leadership, we have countries like Angola, who has decided to support financially the continent. We are also encouraged by the conversation that has been happening with private like Ethiopian Airways and so on. So it's too early to actually assess how far we've reached, but we have significant positive sign on the adherence of encouraging within the continent how this approach is being welcomed. But beyond, at the global level, also in the different conversation that the DJ and the leadership has had when they were in the US, in Norway, and other, this is something that is very well appreciated. The fact that we are pushing countries to increase their domestic funding. So today we were meeting the Director General of NPHI in DRC, where the country is currently at 8% in expense in the health sector, and they are also seeing how they can increase because they have been affected by the pause or the cancellation from the USD, and they all realize that a significant investment has to be done by countries so that they have their own autonomy. So we believe that the movement is on. It's too early to really assess, but as we go, we'll definitely give you more feedback. Dr. Messi, do you have the answer on the question of the OCV supply available? Their own autonomy. So we believe that the movement is on. It's too early to really assess.
This year, Sudan is receiving over 1 million doses of vaccine from ICG, and also they received last year over, I think, 9 million from UNICEF. So different partners are also supporting, just the way we are doing mobilization for Mpox vaccines to affected countries. But the details are for the entire continent, that which we're not able to provide today. We might be able to look deep into that and bring you accurate figures next week.
Thank you, Dr. Masi. Let's take the last two questions from the chat box. We have one question regarding the health sector emergency plans or annual interventions strategy. The question is, has Africa CDC done a strategic impact assessment or an M&E evaluation follow-up on regional medium-term emergency programs or projects, especially where we have diverse seasonal outbreaks? That's the first question. And then the second one is on coordination of efforts between Africa CDC and national health ministries to ensure equitable access to Mpox vaccines and treatment, especially in high-risk communities. Over to you, Prof.
So thank you. For the first question, it's really spot on. We are in June. We are really at the midterm when those assessments are being done. Most of those data are being collected, and as soon as we have the outcome, therefore, we'll be very happy to share with the community and the journalists. So on the coordination, Africa CDC and the country and the Mpox vaccine is actually not Africa CDC. We have the IMST, where we have Africa CDC, we have WHO, the college, we have all the partner, UNICEF, Gavi, that are critically involved on the mobilization of the vaccine, on the supply chain. We have all those donors, the ERA and so on. So we have a very transparent and strict mechanism on how we support countries on their plan based on the epidemiology to assess the quantity of the vaccine that they need. And this plan is now assessed, and then we compare the plan with the epidemiology, but also to the dose that are available. And once we respond to country, we have this one-on-one with country to explain how the allocation are being made. As mentioned, Uganda just received 97,000 doses, which is part of the third allocation. Sierra Leone will be receiving 50,000 doses based on still that third allocation. So we have that communication with countries. And also the new country, the sixth country that I've mentioned in the pipeline of receiving vaccine, we have that conversation highlighting that once the vaccine are available, what can we strengthen in your response so that you can still control while we are mobilizing, when we are looking for vaccine to be more available. Thank you. Over to you, Director.
Yeah, thank you, Prof. And with that, we have come to the end of the weekly briefing this week. I'll hand over back the floor to you for your closing remarks. Over to you, Prof.
Thank you. Thank you so much, Director. So before that, Dr. King has highlighted that Zambia has received over 100,000 doses in May of OCV, and the ECG has approved 1 million vaccine for Sudan this year. So this is going back to the question that was asked previously. So to conclude, really, it's to say thank you. Thank you for all the colleagues who are fighting. It's a fight in different countries to respond to Mpox, to cholera, and other outbreaks. But also a big thanks to the journalists who are the majority of the people who are joining this press briefing. Why thank you? Because you are supporting us, you make us accountable, and we appreciate when in an editorial you emphasize the African leadership that also need the global responsibility. It's also contributing to appreciate that as IMST, we have much more partner than the 28 that we are always mentioning. We also have you as the journalist, because you are catalyzing our effort and ensuring that those who are in the position to support actually support, but also in the side of the member state to have the proper information, because all of you, based on the question you ask, you will go back, you write an article, and your leaders, your community will better appreciate what is going on. Your questions are also pushing us, challenging us, and ensuring that we can triangulate the information so that the response we provide is actually adequate and homegrown solution. So with that, we thank you, and then we'll be happy to be with you next week, Thursday, same time, in the same channel.
Recording stop.